Okay, hi everyone and welcome. Today we are here for Album Health's May workshop, Evidence-Based Strategies to Improve Mental Health and How to Adhere to These Strategies. My name is Alexa Colella and I am a recent graduate from the University of Iowa as well as an intern here at Album Health, and I will be your moderator today. So any questions that you have, feel free to send those in the chat. I will be keeping an eye on that and letting Erin know. Without further ado, I will go ahead and present Erin.
Good morning, everybody. It still is morning. And thanks for being here. I have to just forewarn people as we are doing this workshop today. I am at home from my home office. There's a dog right next to me. If the dog barks, I'll shoo the dog away. I don't perceive any other distractions will occur, but I apologize if that happens. So a little bit about me before we start. I am a licensed psychologist. I'm licensed in the state of Iowa. I went to Iowa State University and got all of my graduate degrees there. I also have a master's in science, in exercise science from Iowa State University. I'm involved in multiple divisions with the American Psychological Association, active on multiple boards, faculty at Drake University, and CEO of a company called Album Health, which is a mental health solution. And I'm married, 2 kids, both are out of the house and mostly off payroll, and based in Iowa, just outside of Des Moines. So that's a little bit of background on me. And today, really excited to meet with all of you to discuss evidence-based strategies for anxiety and mood disorders. And then also, the second part of the discussion is to get into, now that we have the things that we're supposed to be doing, how do we do them? That tends to be a real issue in the treatment world, but also in the individual world. I mean, we all kind of know what we're supposed to be doing, but oftentimes we don't do those things. So we'll dive into the literature in both of those domains. Before we start, just to go over targets, the target audience, conflicts, disclosures, talked about the dog. That's one thing that might conflict with the presentation. But I really see this presentation is sort of the target is everybody. I know you're supposed to be very, very, very specific with the population, but my intent is that this presentation can be useful for people who provide care and help others, for employers, and people who work in companies and are decision makers, that there are policies and actions that can be taken based on what we discussed today. And then at the individual level, my hope is that people will extract some benefit for themselves. So really, those are the 3 target audiences. And then what we will be discussing, this is the 3rd bullet. I want to be very clear on this. I largely leaned on a peer review treatment guideline site called UpToDate, UP, capital TODATE. This is really the science of the science. So all of the evidence that I'm reporting to you today comes from systematic reviews and meta-analyses. That is not the only way to gain knowledge. You can gain knowledge from personal experience and others' experiences, but this is the pure science I'm bringing to you today. So I think it's kind of cool. It's an area to look at. It's really treated as the Cadillac of knowledge, particularly in the treatment space. So we will be diving in there. I will be adding some commentary, but I've reviewed the literature, leaned heavily on UpToDate systematic reviews, and I'm going to be distilling that to you all today. I am CEO of a for-profit company called Album Health. That doesn't really come into play much at all today. We do some of the things and help employers work on some of these things, but really no additional conflicts. Also today is available as applicable. You can get continuing education, 1 hour, 1 unit of continuing ed, and we'll talk about that at the end. If you have questions, please enter them in the chat. I will pause a few times during this discussion to field any questions that are out there, and we have a built-in Q&A at the end. So without further ado, let's roll. Learning objectives. I hope you all leave and you're pretty clear on what the evidence-based strategies are for anxiety, for mood, and for stress. I also hope that you're can discuss and articulate the strategies used to improve adherence. And one fun one, this is a fun learning objective, is knowing the difference between stress and anxiety. I find that most people really don't. And even I go like, at times around what the differences are. So we will start with an interactive question just to get our place in the mental health landscape. Guesses here, and please enter your response in the chat. What is the annual prevalence of mental health conditions? Annual. Any given year, people who have a diagnosed mental health condition. Prevalence in the United States. Is it 5%, 14%, 23%, or 35%? I'll give you a minute to chat in your response. Not a minute though, Alexa, like maybe 20 seconds.
So we have received 3 C's and 2 D's, so 23% and 35% so far.
But the winner is C?
What's the winner?
Well, what did people choose? Mostly.
We've got, all right, we just had another C in, so we've got 4 C's.
Bam, C, correct. So it is about 23%. I know we have people who provide care and involved in mental health in this workshop. That seems to be an underestimate, and some experts think that it's a gross underestimate. But that is the official number really used by NIH, NAMI, CDC, wherever you look, is right around 20 to 25% typical annual prevalence. Next question, since you all are so good, let's break it down: anxiety and mood disorders. I'm using old vernacular with mood disorders. It's really now depressive, bipolar, and other disorders, but let's call it mood disorders, which encompasses depression, and anxiety disorders. Prevalence of anxiety disorders and mood disorders annually. 1910, 1019. So it's just flipped. Number one is anxiety more prevalent than mood? And number two, which numbers fit?
So far, we've received several A's, 19 and 10%, and then a B as well, so 10 and 19%. It looks like the winner is A.
All right. Bingo, A. I want to point out a few things here. When you do this discussion on evidence-based therapies, I decided let's talk about mood and anxiety. Well, look at the prevalence numbers here. We just said annual prevalence overall is 23%. Now we're seeing anxiety annual prevalence is 19% of the population. So, and mood is 10. And of course, there's comorbidities with anxiety and mood. And a lot of the evidence-based treatments and that we'll discuss are overlapping. So the bulk of the diagnoses come from those two families, the mood and the anxiety, particularly the anxiety, where other disorders are really a small fraction of what's going on in the landscape. This is what's prevalent. So it makes sense that we would hit this first, since many of us are experiencing it, working with others, etc. So great work, everybody. That's impressive. Okay, I talked about I'm using the terms mood and anxiety disorders. This is from the DSM-5, just a quick refresher. Anxiety disorders are over here on the left. And those have been pretty stable as the DSM has altered. DSM-5 was a real shift in how we classified and created diagnoses. And now what I said before, mood disorders are no more. It's now depressive disorders and bipolar related disorders, et cetera. And these are the disorders that fall into this category. By and large, the most diagnosed in the anxiety state is GAD, generalized anxiety disorder, and on this side of the fence is MDD. Everybody probably knows that, but that's where the bulk of the literature is and the bulk of the incidence is. So that's, I'll still use mood and anxiety because it's just comfortable for me. And let's start with anxiety. And now we're diving into the evidence-based treatment. So based on the literature, systematic reviews, meta-analyses, quick word on how these are done if you don't know. Authors go in, they scour the universe for literature that contain randomized controlled trials that address anxiety. They create very strict inclusion and exclusion criteria. And what happens is they keep a sliver of the randomized controlled trials that have been done make the cut as being quality enough to be included in these systematic reviews. They then take the data, pool it, run a meta-analysis, and then report findings. So they basically have said, these are the best studies, these are the Cadillacs, we're going to take all the data, and then we're going to tell you what they say. I've dumbed that down, but that's basically what happens. These are the findings from those systematic reviews. Up to date has nothing. They don't recommend anything that doesn't come from those reviews. So that's really what the medical world is looking at. So most effective treatments based on the systematic reviews are two things. For anxiety, cognitive behavioral therapy and pharmacotherapy. Those two are the first line treatments for anxiety disorders. Probably not a big surprise to people. And really the recommendations are that whatever your preference is, that's what you start. It does seem like a combination of both may be better. Although that's not always the case. That's not a strong recommendation in the literature. So let's start with CBT and dive into cognitive behavioral therapy. One that I love. Again, I am a psychologist. I've done a lot of work with CBT and gone through different certifications here, but really great. It's teachable. You follow a method. Oftentimes I'll be using a workbook as I'm doing CBT. It's really amenable to self-help. I have some resources down here that I really recommend, but really, really effective in sort of altering thinking and changing behaviors. But response rate to CBT is about 50%. This includes traditional CBT, but also the new wave of CBT therapies, including acceptance commitment and mindfulness-based cognitive therapy as well. Typically, CBT is about 10 to 15 sessions for 1 hour. These are the recommendations as well for efficacy. And it seems like computer-based CBT and those that you can get over through programs, even on your phone through apps, seem to work as well as if you have somebody working on these in person. Core components to CBT include education, self-monitoring of thoughts, behaviors, symptoms, relaxation training, cognitive restructuring, exposure work, and relapse prevention. So those are the core components. So when you are looking at CBT and whatever level you're looking at it, really make sure that those characteristics are present in the programs that you're using. Other therapies seem to work well as well, like psychodynamic emotional regulation, acceptance commitment actually was separated out for some reason, seemed to have limited support, but CBT is certainly the Cadillac. Few resources here I want to discuss. If you're interested in CBT or you might use these already, the Cognitive Behavioral Workbook for Anxiety is fantastic. Mind over Mood, wonderful. This can be used for both mood disorders, but also anxiety. And the Anxiety and Phobia Workbook is actually my personal favorite. So I have a history of panic, and this was actually my introduction into being a psychologist and getting involved, but this was my savior back in the day was the anxiety and phobia workbook. So highly recommended, very, very user friendly. And that's CBT, number one of two first line therapies for anxiety disorders. Number two, pharmacotherapy. I don't know if we have prescribers here. I will disclose I am not a prescribing psychologist. I, of course, consult quite a bit on the medication side of things, and I'm pretty darn familiar with that, but I'm not writing the script. In Iowa, psychologists can prescribe under typically supervision. So that happened about 10 years ago, actually. So in pharmacotherapy, what is recommended, two classes of medications are primary recommendations for anxiety disorders: SSRIs, selective serotonin reuptake inhibitors, and SNRIs. Typical SSRIs include Paxil, Zoloft, Lexapro, Celexa. The SNRIs include Effexor and Cymbalta. Well known as additional medications are the benzos, the Ativans and the Valiums and the Xanax, but also additional medications like Remeron and Buspar. So those are effective, but are not considered first-line therapies given they're dirtier drugs and have more side effects and can be habit-forming in the case of benzodiazepines. So they're a little more dangerous, but SSRIs and SNRIs are considered the first-line therapies. I also provided something. I'll go back. By the way, this presentation is in your invite, so there are a number of links here that I think are useful. This is one of my favorite that I use all the time. I literally keep this up above my desk. I refer to this constantly. The quick reference to psychiatric meds. So by class, you have the generic name, the brand name, the dosage range. Really helpful if you're not a prescriber and don't have this all in your head, but you're providing care. You're looking to help best manage your own medications. You're working with somebody else. A lot of good information here. Dosage range is important. Some of the side effects and the mechanisms of actions, that's dopamine, that's norepinephrine. And it gets into all of this information about the typical medication used for psychiatric conditions, has the stimulants, antipsychotics, etc. It also, interestingly, has some of the information on the evidence around over-the-counter supplements that you can find and some of the recommendations here. So a lot of good information there. Please, I recommend everybody probably print that out, put it on the desk, keep that around. It's a nice one to have. So first line, hopefully everybody knows this. This is part of the targets for this talk: CBT, pharmacotherapy, anxiety disorders. Specifically SNRIs and SSRIs when you're looking at the pharmacy side of intervention. A little bit on complementary treatments. So when systematic reviews are done, basically what you see here on the screen are, well, these might work. And the typical narrative that follows something like, let's say, Tai Chi is that there aren't enough quality studies for us to say, yes, everybody should do Tai Chi. It's just that randomized controlled trials are hard, they're costly, they're difficult, it's hard to meet the strict criteria required for systematic reviews. So they get the sort of, yeah, these might help, try them out. But these do not seem harmful to most people, the things that I'm presenting today. And some of them have absolutely no side effects. So I highly encourage, you may have done some of these things, you may consider some of these things to try them out. Complementary treatments include exercise. Now, here's where I will make a recommendation you see here at the bottom. I believe that exercise is a first-line therapy right alongside CBT and pharmacotherapy. I might even give exercise a little bit of an edge over all of those things. Here, we do at Album Health a lot of work with exercise. Type. Here's a podcast that we have with Dr. Jacob Meyer, who's at the Department of Kinesiology at Iowa State. This was a great discussion on exercise, and I really encourage you to check him out. That's me here, and that's Jacob Meyer, and that's John Brandon, another psychologist with Album Health, discussing exercise. And a couple of things that we discussed here is the most important thing is to exercise in general. He's pretty clear on this is a first-line therapy for depression, anxiety. He's running clinical trials out of Iowa State. In fact, I've been getting announcements to join and distribute. But he has a wealth of knowledge. I encourage you to check out this podcast and his work. It's pioneering, and he's around here if you're from Iowa. So really neat. But what Up to Date says about exercise is that aerobic exercise is pretty clearly beneficial to anxiety. Not the amount of studies we want, but pretty clearly effective. High intensity interval training, or HIIT, also pretty good results here. That's something I hear about quite a bit. And then low intensity training, just walking. That zone 2 cardio, that's the fad right now. We discussed that in the podcast as well. Shouldn't say fad, it works. Is also very helpful when we're talking about anxiety. Mindfulness, meditation, things like yoga. I think of yoga as being a form of meditation. I think yoga is fantastic. I think the literature is pretty clear that it helps, particularly when you're talking about anxiety. And things like acupuncture. I mean, acupuncture is covered by a lot of carriers. Acupuncture is highly present in the VA system, so there's clearly efficacy around acupuncture as well. One thing that the systematic reviews are not supportive of are herbal remedies. So for anxiety, that is, that none have been found to be clearly effective or ineffective is the statement. So weak around supplements as well. And in general, what I think is true is that exercise, it's really whatever you do is the best, whether it's HIIT, whether it's low intensity, whether it's cardio, whether it's anaerobic, whatever it might be. And I also believe that frequency is the most important. The thing that you'll do the most often is the best. And you always want to think about frequency, intensity, duration when you talk about exercise. So that's it. If you have questions, by the way, on any of this and want to expand on any of these points, chat, but I'll be pausing here soon as well, just to go over any of this. Now let's switch to the mood disorders. As a review, anxiety, CBT, pharmacotherapy, the heck with it, I'm adding exercise. Those are the 3 first-line therapies when you're thinking about anxiety disorders. So if you know anybody with anxiety, and the data shows that you probably do, and it might be you, I think it's important to think about those 3 things. Mood disorders, let's shift over here, MDD being the primary mood disorder that's present. A couple of things here. It's really important to assess both anxiety and mood. The PHQ-9 is the standard depression questionnaire. 9 questions, really simple, puts you into categories of mild, moderate, moderately severe, and severe. Questionnaire links are here. PHQ-4, which measures both mood and anxiety, and PHQ-9, again, is just mood and depression. Okay, systematic reviews. Step 1 is to assess yourself, others, understand what category they fall in, and the reviews break people into 3 categories: mild, moderate, and severe. Recommendations are different based on which category you fall. This is interesting to me. I love doing these talks because Up to Date it tells you when the findings and the recommendations have been updated, and this was done, as you see here, this month. So oftentimes it'll be 3 months till I go in and sort of look at what the research is showing. And oftentimes it's different, um, which says a lot. But most effective treatments for mild depression, again, using PHQ data, they essentially say just surveillance, just wait and watch. Mild depression, mild mood issues, normal. Everybody goes through that. I would say on the other side, mild stress, mild anxiety, also normal. Wait and watch is the approach. They do recommend exercise for everybody. So the treatment recommendations are everybody should be exercising. So this will apply to all categories. So exercise, wait and watch. If mild symptoms leak over past the 3 month mark, that's when you might want to consider adding psychotherapy, antidepressant in this case. And I'll fast forward to some of the findings. It's the same antidepressants, SSRIs and SNRIs, that are considered the first line treatments for mood. Moderate depression, this is where exercise remains, of course, but you want to consider one of the two. This is where the recommendations are, yes, add the psychotherapy, yes, add the antidepressant. And you might want to consider both if you've had moderate episodes or more before, or if the symptoms have been around 6 months or more. Okay. And then severe depression, this is where you really are thinking about combination therapy. The evidence is pretty clear on the mood disorder side. The combination therapy is the best, where on the anxiety side, it's not as clear. So you do want to be doing psychotherapy that works for you. CBT, again, is the Cadillac, and the antidepressant and potentially other medications. And you really want to be closely monitoring symptoms for heightened care. There are all sorts of this trees out into a number of different types of interventions here. I can expand upon this some more around what to do in each category, but these are the basics with mood disorders. So a little bit more on psychotherapy related to mood disorders. Number one, psychotherapy and antidepressants have similar effectiveness. So when we're talking across the intensity categories, it's hard to differentiate which one works. So you really have to go on your experience. You may have to try different psychotherapies to understand which one best works for you. And you might have to try different medications to figure out which one works for you. I'm guessing everybody knows that and has had that experience. Also, interestingly, on the mood disorder side, the statement is that the major psychotherapies really have generally equal effectiveness. Where CBT is the clear winner on the anxiety side, it's one of multiple that have been demonstrated effective on the mood disorder side. So CBT is again one of the recommendations, along with interpersonal process therapy. I absolutely love that. Not many people know what that is. But that also is a pretty repeatable workbooky type of approach. I did not provide a link here to my favorite book, but I can. Behavior activation therapy is demonstrated effective, and psychodynamic and just supportive psychotherapy. All are recommendations based on systematic reviews. So a little more flexibility here to match with the psychotherapy that might work. Antidepressants, there's not much more to say here. Went through the resource. SSRIs and SNRIs are the first line, and then it really gets kind of a lot of things thrown in, and a lot of medications from different families thrown in. If you have sort of that recalcitrant, difficult to treat depression, and even ECT makes its way into one of the things that we continue to use quite a bit for non-responsive depression, and it's done quite a bit. I see it quite a lot. So tricyclics and Remeron are considered the second tier after SSRIs and SNRIs. Again, more side effects. So those again need to be considered, and that's why they're not first line, is the side effects and the dirty profile. On the mood disorder side, additional things proven. Same thing, but this was the quote from the systematic reviews: exercise for all. So this is why I consider exercise really the first line of the first line. If I haven't said that enough so far, it is strongly recommended for anxiety. It is strongly recommended for mood and depression. The recommendations on the mood side, there is evidence for intensity, to have the exercise take on a moderate to vigorous intensity, and that as intensity goes up, there's a negative correlation with depressive symptoms. They go down. And the way to measure intensity is typically, I wear two of them, some sort of monitor, stop and take your pulse, but you want to be at 50 to 80% of your max heart rate. Your max heart rate is estimated as 220 minus your age. So for somebody like me, I'm 220 minus 52. Let's say it's 50 to make the math easy. So it's 50 to 80% of 170, which I can't do that math very quickly, but it's somewhere around 130 to 155 is where I want my heart rate to be for maximum efficacy for depression. Resistance training is also supported. This is not seen as strongly on the anxiety side, but doing strength training is supported as an intervention for mood and mood disorders. The recommendations are from a duration, 30 to 60 minutes, at least 3 times a week. And a wonderful recent review that I linked here for you all does show a clear dose response relation between exercise and depression. And this is a 2023 systematic review, concluded at the end: exercise is a core treatment for depression and mood. You know, if this is something you struggle with, that has to be a part of your day to day. Other things, yoga again appears. Tai Chi, internet-based therapy seems to be supportive. Not as scalable as CBT, things like psychodynamic. Other things are more difficult to deliver via computer, but bright light therapy is also supported by systematic reviews. I don't hear about the bright light therapy as much anymore, but the evidence is pretty solid. Attached is a review here, a recent one, and for seasonal affective disorder, which falls within the depressive disorders, MDD, even bipolar disorder, bright light therapy has been proven effective. Acupuncture, again, makes the list. And then a little bit different on the mood disorder side compared to anxiety is that there are some herbals and some supplements that may have benefit, according to reviews. The main one is St. John's wort. That's been around a long time. If people have done that before, what I would say is it certainly works for some people, but it can have some negative effects as well. There are various side effects. You need to stay out of the sun. Some people don't respond to it well, so be careful. Make sure if you're working with any of these things yourself or with others to be working with somebody who's a skilled prescriber, probably a specialist. Some other fun things: monocycline and its anti-inflammatory effects are seen to help depression and mood disorders. There is an anti-inflammation theory around as inflammation goes down, depression does as well. So a positive correlation. That's where omega-3s fit in as well, and some of the diet approaches. And then probiotics is another one I'll point out that literature is emerging there. The concept of the gut biome being crucial to mental health, both on the anxiety and mood side. But in the systematic reviews, we're starting to see information percolate around probiotics and that healthy gut biome. So there's actually a fair amount happening in the literature. Now, stress and anxiety. This is one of the things I hope you can differentiate at the end of this talk. There are really no different recommendations for stress management than what I already talked about in the anxiety disorder side. But The general difference, I hear all sorts of responses when I ask the question, what's the difference? But really, stress tends to be short term and a response to a trigger, usually a tangible trigger, like, um, I lost my job, or I got an F on a test, or had a bad performance review, or I have a presentation to do today. Those sort of things can trigger a stress reaction in the body, but anxiety is something that tends to be more chronic, can tend to linger, and it can be connected to basically nothing. So you're worrying, you're restless, you're tense, you're sweating, and absolutely nothing is happening. Um, those are the two differences captured nicely here in the um, graphic. But again, treatments are really the same, and anxiety can oftentimes be subsequent to stress. So it's always important to manage stress well so it doesn't grow into anxiety and become more of a chronic issue for you and others. So here are the conclusions, putting it all together related to what does the literature show, what do systematic reviews show related to mood and anxiety disorders. First line therapies, exercise, psychotherapy, particularly CBT, fell on both sides. So if you're looking the most bang for your buck, you exercise. CBT is your starting point. From a medication perspective, if these two are applicable, CBT and SSRIs and SNRIs are the families of choice and the medications of choice. Also, in both anxiety and mood disorders, there is evidence for mindfulness, meditation being effective, yoga and Tai Chi, and also acupuncture. So, in conclusion and integrating, these are the recommendations for both of those areas. I will point out everybody should be doing exercise. I think everybody should learn CBT because why not? The only thing you lose is an investment in time. There are no side effects. You'll learn a great deal. You'll be more helpful to yourself and others. It's really easy to do because it's kind of scripted. Where on the medication side, you may have some negative side effects, but SSRIs and SNRIs tend to be pretty safe. And these, of course, as applicable for you. So I'll pause there. Any questions, any feedback, anything related to what I said? Are these things just a yes or a no? Would be great in the chat. Why if, yeah, this is what you expected that the reviews would show? No, if it's different. Yes.
Yeah, we had a yes come in. We have some other individuals still typing.
Yes. Okay. I do think future trends and watching these reviews come out and the formal recommendations hit and up to date, I get excited. Like, okay, what's it going to be? I get alerts when things have changed. I go in, what's there? How do you recommend employers? I missed that, Alexa.
Yeah, so we did receive a question from Jennifer that was, how do you recommend employers address or support employees?
Related to anxiety and depression, I assume is the answer or the question.
Yes.
Well, if you think about these recommendations, okay, and if you think about, let's say 1 in 4, 1 in 5 of your employees has a mood or anxiety disorder at any given time, that's a substantial amount of your population, right? So 1 in 4, 1 in 5, number one, need to have easy, simple access. The next part of this talk, which we'll cram into about 10 minutes, is about adherence, actually doing these things. So some of the answers will come there, like how do you get people to do these things? Because that's a problem. But providing access. So Things like articles on CBT, things like workbooks, some of the things, making that available in digital form, uh, access to, of course, medications is usually pretty easy because the bulk of prescriptions come from primary care. Probably most of the people in employer settings are seeing a primary care provider. It then gets down to adherence. People might have the Lexapro, but they have to take it. People might have the workbook on CBT, but they have to stick with it. That can be, a multi-week program. And then exercise. That's also a challenging one. That exercise has to be accessible. It has to be simple. It has to be reinforced. Um, those are all strategies that are really crucial. And if you think about an employer setting, you need your people exercising, right? I hope the evidence is very clear that your people need to be moving. If they're not, there's going to be trouble. And they need access to these two interventions as well, at least the 20 to 25% of people who are going through things. But I think everybody should have access to CBT. So there are a lot of things that you can do there. And then some of these other things, understanding what's working in your population. These are based on systematic reviews, the necessities, I would say. But then there are other things that people are doing in your population that you should be finding out about. What's working for people? Are they walkers? Do they love Tai Chi? Is there a group of them who do Tai Chi together in the park? Those sort of things, and then making it easier for them to sustain those is my quick response. But we're going to talk more now on, okay, you're welcome. That's what you should be doing, and that's what works. But I'm going to break down quickly. There are reviews around how do you exercise and what helps people adhere to exercise recommendations. And then psychotherapy and medications tend to kind of be the same, that the determinants of adherence are really similar. So we'll go through those right now. Try to get 2 reviews, each of these areas. Let's bring together the recommendations. Let's conclude at the end. It's kind of the way my mind works around how to understand. So, last question of the day. Doing exercise the way you're supposed to, completing psychotherapy and attending appointments and where it is the way you're supposed to, and taking your medications the way you're supposed to, that's called adherence. What are the general adherence rates? Basically, you're doing what you're supposed to be doing for those 3, and it tends to be about the same. In the chat, are people 90% adherent to what they should do, 70, 50, 30, 10% adherent to what they should do, 10%, 20% adherent? That means, think about the medication. They're only taking the medication 20% of the time that they should. Usually it's daily. Any other guesses? 25. Let's wait for one more. So we have 20, 25, and any 50. Angie. Winner, winner, chicken dinner. 53%, 40. Okay. You're technically correct. Adherence to treatment recommendations vary by condition. When we're talking depression and anxiety disorders, I've seen numbers anywhere from 20 to 70% adherence, depending on what it is. Medication adherence tends to be about 50%, which to me is appalling. Just taking the medication. Bipolar disorder is far worse, for example, but that makes sense within the mood family. Exercise adherence is right around 47%, and psychotherapy is right around 50% as well. They're really all about the same. So only half the time are people doing what they're supposed to do. Therefore, there will be persistent symptoms, persistent problems with both mood and anxiety. Classic study in 1985. What determinants are present when people engage in exercise? And it's broken down into two areas. What are the personal characteristics of people who exercise and stick with it? They've done it in the past. There's supervision. somebody's helping and has expertise, but also somebody's watching, right? Makes sense. At that time, it was high risk for heart disease. That scared people enough that they would be adherent. They didn't want to have a heart attack. They didn't want to have a stroke. Uh, these people had high self-motivation, so they had that fire in their belly. They enjoyed exercise and tended to enjoy life and things in general, and they had the skills necessary to engage in exercise. So it's not somebody who's falling over their feet. It's somebody who, yeah, they can generally function pretty well from a behavior perspective around exercise tasks. In the environment, I forget who asked the question, but when you think about employers, really think about this second column here. Spouse support and family peer influence affects exercise behaviors. If others are doing it, people will. If somebody in the home is supporting it, people are more likely to exercise. If people perceive they have the time, another recommendation for employer settings is set time for people to exercise. Make sure that that's something that fits into their schedule. And of course it does, but help people understand that they have the time. And then the final one, incentives. A wonderful driver behavioral solution that you can put in place is provide incentives for people to exercise. And on the exercise front, it should be just that. You get this if you exercise. And the way to know that people did it, self-report. That is the way across all of the adherence, is just let people report if they did it or not. That works quite well. So really simple. Other things, in about 5 minutes, we'll move through all this. Second, more recent review around factors associated with adherence to exercise and physical activity, labeling the barriers, knowing what might get you out of it and sort of addressing those barriers and moving those out of the way. Getting professional evaluation can help. Bold are overlaps from the older 1985 classic review. Self-efficacy, a belief that they have the skills, social support, again, supervision. A couple of things as well that I think are really important when you think about exercise is don't set too far away, too big goals. Like, I want to exercise every day this year. Well, you're set up for failure. Really talks about 1 to 2 months. Just set a short-term goal around what you want to do, particularly related to frequency, and you want to do something more than once a week. So when you get to that 3 times a week of exercise, physical activity up through daily, that's when people tend to stick with it. But it's down 1 to 2 times per day that you're exercising, like a weekend warrior, that tends to fade. So those are some of the recommendations of how to actually do exercise. On the medication psychotherapy side, this is around patient adherence and how to get people to do those two things. Simplify the regimen, modify beliefs, provide rewards, clear communication, education, set reminders. This gets a little bit different. It's kind of fun that we have phones now. There is clear evidence around setting a daily alert in your phone to take the med, to schedule the counseling session, to put it in a calendar as a weekly repeating event with counseling. The literature shows that you're more likely to go, right? And even from a provider perspective, if I put a penalty that, Alexa, if you don't contact me within 48 hours, you get charged, and you sign that document, you're more likely to complete your course of psychotherapy. So those are there are an array of things you can do to improve adherence on that side. More recent, education. So things that help people adhere is they understand, they're literate, they know that it will help them, they understand how it will help them, they have access to educators. So again, we get into that supervisor thing, that there's an expert there, there's somebody who's paying attention and looking. Simplicity. This is around medication specifically, making it simple. Cognitive behavioral therapy on the adherence side shows up through something called motivational interviewing. Should have linked that. wonderful book about how to, an approach to help people engage in behavior change and adhere, and a whole framework around doing that, reminders, alerts, and then incentives show up again. So, these are things that are overlapping, and then bringing in all the data around adherence, best practices, have a supervisor there, have support there. One thing that I skipped over is measure adherence. If you're ever doing anything, if you're an employer and you want your employees to exercise, you have to measure it. You have to have some mechanism in place to measure it. Enable social support, enable peer support, provide education, provide incentives. All this cluster of things shows over and over around the literature. Again, these are systematic reviews around how to get people to do, and yourself, to do the things that you need to do to promote health, and specifically adequately address anxiety and mood is what we're talking about today. So these are the 9 factors that the research coordinates on. Okay, I went through that last part pretty quickly. Apologies for that, but questions on adherence? I don't know if there's a follow-up to the one about employers and employees. Anxiety, mood, exercise, CBT, medications, adherence. Yeah, you can certainly unmute. I believe people have the ability to unmute. If you'd like to voice it, you can chat it. I don't know if we have any Alexa in the queue.
Yeah, it looks like I've received a question here. It says, can you walk through your experience with helping people adhere to health activities and what employers can do to help get people to do things to improve their mental health?
Okay. So I'm going to highlight a few things on this slide here. Incentives must be in place if you want to get people. Label the targeted behavior. Try to keep the goals behavior oriented. Measure, provide incentives, and then really provide, I think, about the infrastructure to get people to adhere. So exercise, let's highlight that one. What might that look like? If you're wanting people to engage in more movement, okay, measure. Measure how much movement people engage in, whether they're reporting steps, whether they're just telling you how many they did per day, whether you're working with a partner like Album Health, we gather that data, we can give it to you. That's kind of an easy way. Provide some incentives. So we really want you to exercise. Here's why. Create groups and provide time during the day to do that at work. So a lot of these things, if you're an employer, you need to carve out the space. And I think the ROI will be very clear. So when you go to leadership and go, hey, we want to carve an hour out of the day, we think it will do X. That's a pretty easy equation. Those people they'll stay, they'll be more productive. Healthcare costs should go down. Absenteeism should go down. There's a cluster of things that you can really measure, but those are some of the basics around getting people to do it. All right, we're close to the end here, aren't we?
Yes, we are. We did have a follow-up question. Just based on exercise, it says, where should I go to get support with exercise and what I should be doing?
So a tidbit from the reviews, exercise is increasingly recommended to physicians to recommend to their patients. And what I've seen for the first time is a lot more trainings and a lot more recommendations on how to write exercise prescriptions. I'm not familiar with that occurring yet, but it is worth a try. I know there's increased training around in the primary care space around exercise and prescribing exercise and more training is happening. Aside from that, real experts in that space tend to be the exercise science people, the personal trainers. Be a little careful around who you're getting information from, but those tend to be the experts who are more accessible. And in addition to that, I mean, the CDC and the NIH and going into the organizations who are bringing in the data and distilling recommendations, I mean, that's really still what should be followed is the CDC recommendations, which, I can say those off the top of my head, but they provide the guidelines and then they give ideas and other ways to adhere to those. So I would really use those resources most, but I'd be interested in challenging your primary care provider to, hey, I'm interested in exercise. How can you help? And I think we'll see more and more people being able to write out a pretty competent prescription for you and meet with you and understand what works for you. And that's where we're headed. Oh,
All right, that should be it for our Q&A. Just a reminder for everyone that the recording will be made available after this meeting is concluded, and the presentation has been attached to the invite, so everyone should have access to that. Again, one continuing education unit is available, and that is for 1 month until June 30th of 2024. You will have to view the session in its entirety, complete our survey, and then Album Health will email a certificate to you for your completion. If you have any additional questions, requests, or feedback, we have listed Erin's email address there. Thank you for attending our presentation today.
thanks, everybody. Have a great day.